cover. So let's jump. Okay. So yeah, there's a lot to cover here with the neoplasms. But basically, we'll start off by dividing the cancers, right? So, are we talking about cancers of the lymphoid lineage, or are we talking about cancers of the myeloid lineage, right? I suppose you could have cancer straight up from the hematopoietic stem cell, but that's I don't think that's very common, right? That's probably a different thing. More likely, we're going to have one of these two. Okay, so what does a myeloid one look like? So as we know, myeloid cells don't hang out in the lymph nodes. They're either in the bone or they're in the blood, right? So they could be leukemias. There could be leukemias. If it's a white blood cell, we can call it a leukemia. If it's a red blood cell or a platelet, we will call it polycythemia, or we'll call it thrombocythemia, right? So we don't call it a leukemia anymore. So let's jump into here for the myeloids, right? So there's three kind of main classifications here. You can have the chronic, the myeloproliferative, which also we call chronic leukemias. Or right here. What these are normal looking cells, but there's a lot of them for some reason. There's myelodysplastic, which there's a lot of them as well. And they're pretty mature, as we were saying, but they look weird. So these guys don't necessarily look ugly, but there's a lot of them. And the worst of it is if you have myelogenous leukemia, which is you have a lot, and they all look really young. They all look like the blasts. Blasts are just what we call the precursor cells, right? Because they all end in blast. Myeloblast, lymphoblast, such and such, erythroblast, so and so. They're all blasts. So you have a lot of blasts. And there's over 20%. That's when we call it acute myelogenous. And I guess I'll go around as well. But acute myelogenous will look quite similar to acute lymphoblastic. So I suppose if it's immature like that, it's pretty similar now, right? The cells themselves will not even look that different because they're so early on in their development. Whereas if you had right over here, the more mature looking cells, they will look different, right? And they will also behave more like their adult selves, right? So the main thing we have to keep in mind also is that typically it's easier to control a mature one and harder to control. I don't want to say control, but these ones are more dangerous in the short term, the acute ones, because all of a sudden you can have big proliferation and it leads to death. But chronic, it take more time. That's what's going on. So that's a basic lay of the land. For lymphoid, we're not as much doing this as linearly, right? From mature to mature and ugly to very ugly, like because they're young. Over here, it's more of a matter of whether, first of all, we ask if it's Hodgkin or not Hodgkin. So technically, this acute lymphoblastic is a non-Hodgkin as well. Hodgkin or non-Hodgkin, right? And that depends on what it looks like. And then we ask for non-Hodgkin T or B cell, right? And for Hodgkin, we ask what kind of Hodgkin. I think it's sort of it's not arbitrary. It will affect treatment, but I don't think it's as good of a division as this one is, right? Okay. So, myeloproliferative right here. Myeloproliferative. Either we have too many red blood cells, we have too many platelets, or we have too many granulocytes, right? If we have too many granulocytes, we call that chronic myelogenous leukemia. A ton of basophil and eosinophil. And this is normally caused by the Philadelphia chromosome, which actually a lot of these could potentially be caused by that. Cause a fusion gene, causes some weird expression. So transcobalamin is I think it's a B12 transporter. So I think what happens during this, if you have high neutrophils, it will look like you have high B12 because all the neutrophils are carrying this stuff, whereas in reality it's not necessarily the case. So what happens at that Philadelphia chromosome is you get a fusion called BCR-ABL, and that's the JAK-STAT. We talked about JAK-STAT. We love ROS JAK-STAT. So just like the same thing happens with the T cells. The same thing happens here. But anyway, it'll start proliferating a lot. Okay, classic. You get a ton of growth in the bone marrow. And you also have a ton coming out of the bone marrow. You'll have low leukocyte alkaline phosphatase. I'm not entirely sure about that one actually. Low in paroxysmal nocturnal hemoglobinuria. Let's look at that. Okay, so this will tell us if it's a short-term thing going on or a long-term thing. So if it's high, that means it's probably not chronic myelogenous leukemia, because it's probably what we call a leukemoid reaction, where maybe there's just a big infection, and there's a ton that we need, right? You can use imatinib, which is an inhibitor here. And we'll talk about Gleevec later as well with the other drugs. So that's chronic myelogenous. Chronic myelogenous leukemia, granulocytes, right? Because it's myelogenous. It makes sense. For megakaryocytes, there's two flavors of a lot of megakaryocytes. There's a lot of JAK2, apparently, is in the mutation JAK2. Anyways, cause a lot of proliferation. And it could cause either JAK2 or it could also be a high amount of this thrombopoietin receptor. It's the same mutations that causes these two problems. The only difference is primary thrombocythemia is not going to be killing your marrow. It's just going to be just high platelets. Okay, whereas myelofibrosis, primary myelofibrosis, myeloid metaplasia, is when you're pushing everything else out. You have so many of these megakaryocytes, it's pushing everything out and making your marrow kind of messed up, a fibrotic marrow. And that will cause more problems, right? It'll damage all of your other cells in production. You have myelophthosis. These sort of weird looking blood cells, and I think the reason is I think it just squeezes your cells in the wrong way, and they just end up messed up. So those are the two flavors of high megakaryocyte. High red blood cell is what we call primary polycythemia. Primary polycythemia. So in general, polycythemia just means red blood cell. Whereas pancythemia is all the blood cells. So poly, I think it's just because people like red blood cell a lot. That was the first one to be focused on, so that's why we just call that one polycythemia. Also called rubra vera, and this is a JAK2 problem. As you've noticed, a lot of these affect JAK-STAT because that's a major proliferation pathway. Where you're getting a lot of red blood cells, and that could be regardless of the amount of erythropoietin, because if we remember, erythropoietin is made by the kidneys, and there's only so much to go around. So somehow it's going to not care about that anymore, and rely on itself to grow. It's going to be independent. We don't like independence in the body, honestly, because that is risky. So a lot of thick blood is going to make clotting a big factor, right? Or also bleeding, because too many red blood cells is going to squeeze it's going to mess things up, Pulmonary congestion is going to cause your skin to be really red, right? I think I actually met a patient that might have had this disease. Although actually I was told she had a lymphoma. But anyway, it might have also caused something like this, but it caused their skin to turn very, very red. So that's quite closely related to that. All right, so we talked about all these different types of too many cells, and that's all the lineages. So that's all of them. Myelodysplastic just means that your cells are bad. All right, you have a lot of them, and they're also bad. These ones, the cells aren't necessarily bad at their job. You just have a lot of them, So your precursor cells will all be very weird. So you could get ring sideroblasts, which is when your I think it's when the ribosomes fail to incorporate, or actually the mitochondria fail to use the iron effectively, and so they just gather in front of the mitochondria. Why do they gather in front of the mitochondria, not the ribosome? That's a question, right? I guess it doesn't have to be the mitochondria. It could be anything. You just have clumps of iron everywhere. A lot of iron in them. You could have a lot of lobes, and we're going to talk about this a little bit later as well, but you could have really ugly multi-lobed red blood cell progenitors, neutrophils, megakaryocytes, and you might also find that you have weird lobes going on. Pelger-Hewitt is when you have weird lobes going on in the rest of the body. So we can go real quick and look at this as well. Now that we're talking about neutrophils, right? Pelger-Hewitt is bilobed neutrophils. So that's could be genetic, but it could also be because of a cancer mutation, and that would implicate this myelodysplastic syndrome. So that would be a bad thing. May-Hagelin, these are giant platelets caused by a mutation that caused you would also have these giant neutrophils crystals inside of them. Not as much problems, but your clotting's not as good. Chediak Higashi we've talked about before, but essentially our neutrophils are not as good at their job. They're not going to look weird, right? I guess they also could look bad. Oh, because they have these huge platelets, and they also have these huge lysosomes. But we could miss a few of these as well. Leukocyte adhesion deficiency we talked about being a problem where the blood neutrophils are not able to leave and enter the tissue, or chronic granulomatous we've talked about as well in the same context. And myeloperoxidase is actually, we didn't mention this, but it's essentially the same thing as chronic granulomatous, but not as bad, because we don't form the what do we call this? It's a halide. This is the acid, right? Right here. So there's that. We can go over this real quick as well. TDT we already know is important in forming our lymphocytes. I don't know if I have that pulled up anymore. I don't think I have it here anymore. But TDT is in pre-B and pre-T, but it's going to help you in VDJ rearrangement. Let me see if I have that in my notes here. I'm going to pull that up. Where is it? There it is. Do I have TDT written here? TDT should be here. Oh, here it is. Terminal deoxynucleotidyl transferase. Important in combining your VJ, DJ, VD, right? So that's a sign that we're still forming a cell. Still forming a lymphocyte. Pull it up again. Sorry, that's not the one. So that's what TDT is. CD10, we'll talk about a little bit more, is a special marker for leukemia. S100, melanoma, but we didn't focus much on that. 15 and 30 we'll talk about in a minute. 34 obviously is related to the hematopoietic stem cell, just our blasts, right? And all white blood cells have CD45, so we should think about that as well. I think, what was CD45 again? What does it do? T cell, we already know about these. 5 is very early on, and then 3, 4, 8 are your more adult ones. 19 is developing. 20 is a full-grown B cell. 25, 103 we'll talk about in a minute. 138 is plasma cell, apparently. And myeloid cells, you have 15, 14, 64, and 33. We'll get back to that. Okay, so back to this. You can have acquired sort of Pelger-Hewitt is where that's why we went there, is Pelger-Hewitt is that bilobe neutrophil. So weird lobing, right? Great. The problem with these is that they're called refractory anemias because the cells can get eaten up, and because they're so ugly and they're so messed up that your immune system decides, these are not worth having, and they'll end up dying once in a while, which is not good for you. All right, so Yeah, let's talk about the acutes. So actually, these acutes are the blasts, right? So many blasts. I previously said I didn't know what would happen if you had a neoplasm of your stem cells, but the answer is pretty much the same thing, right? Is it would just look the same as these guys. There would just be tons and tons of immature cells. And these guys are really not that different, even though they're technically different lineages. The only difference is these guys have some TDT, so they started on the path to being lymphoid cells. So there's actually a lot of different ways to classify these. The French British American one is based on essentially the look of it, whereas there's a new WHO classification that looks at a variety of things, including dysplasias, including genetics, more focused on treatment. So if we look at French British American, the one that he really wants us to know is just the differentiation level of this blast. Maybe it's not fully immature. Maybe it has some traits that we can look at. Maybe we can target. So M3 is promyelocytic. So promyelocyte we've learned about. It's close to early on in the myeloid lineage, but that's translocation 15-7. We're going to come back and look at all the translocations. The main thing to look for that is hour rods. Let's find a photo. They're just these weird crystals inside of your cell, inside of a myeloblast. These weird looking guys. So that's a rod right there. Oh, this one has a ton. It looks a little bit like rutilated quartz. Now that I'm talking about that, right? Got this weird, looks like that. It looks almost exactly like this guy. Although this is jewelry, whereas this is a bad time. That's what this is. So, okay. We could also go for M4 and M5, which are monoblastic. It's going to cause gum hypertrophy. I don't know how I'm going to remember that. And you have M7, which is megakaryocytic blastic. It's like early on towards that. This is going to be hard to remember. Yeah. So actually for this one, the prognosis is bad if you have the Philadelphia chromosome, because it indicates that it's less differentiated. I don't really know why that's the case. I think that's just what they observed, whereas it's better if it's more differentiated like that. So I think Philadelphia, this one here, is actually your M0, right? Whereas these ones are your different differentiated ones, including 15-7. So the promyelocytic is a little easier to treat because it has some specific traits. Otherwise, we're going to blow up. If we try to blow up this M0, we also blow up stem cells. You blow up a lot of other stuff, right? We want the cancer to have some recognizable features. We want our criminal to have a really interesting look to them, right? Imagine if you had a wanted poster, but the guy looked extremely normal, or the woman looked extremely normal. You cannot identify them because they're just so plain, right? But if you had, I don't know, a criminal that, I don't know, has two noses, right? Like that's, how do you hide that? You can't really hide that, right? So you'll find your enemy. So that's M3. M3 is your criminal with 3 noses. Let's go with that. 3 noses. You'll catch this person for sure. Because they're ugly, right? Not that ugly people. Hey, maybe they're really handsome. 3 noses just happens to make them easier to catch. That's all. Maybe that's not a bad thing. Okay, but if they don't have, that's if they don't have TDT. The moment we find TDT, we decide, okay, this is going to be a lymphoblast, right? Because it has at least a few features of a lymphocyte. And so then we can look at these differentiated further. And if it has CD10, so what is CD10 normally, right? So CD10 is found on other cells. So that's not just an immune thing. Let's see if Wikipedia has this. Okay. So CD10 is is a very early lymphoid progenitor sort of thing. I can only assume that it's helpful to keep around so that a cell can grow more easily. But when you have that, it could be good because it's growing at a quick rate. So maybe you can treat that with chemo because it's trying to grow fast. Well, it's pre-B, so it's CD19. So that makes sense, right? They're also going to be hyperdiploid for some reason. It's not going to differentiate. It's not going to proliferate very well. We also have T-cell leukemias right here. CD3 we know about. I can pull it up too. CD3 is expressed along with 4 and 8. 3, of course, is your signaler for T cells. CD2 is CD5 are your helping you commit, and CD7 I don't really know what CD7 is for, actually. Oh, yeah, right. I remember. I have CD7 here. Well, that's IL-7. That's not the same thing. CD7. Let's see if I have it on my poster. I doubt it, though. I don't see it. Okay. In any case, it expresses CD7 as well on the tumor cell. Just pretty abnormal, I guess. Which is, I guess, less differentiated. And is more likely to be at the mediastinum. Why mediastinum? Not terribly sure. But I guess if you have Philadelphia, that's normally not great. You're probably going to be harder to treat acute. So there. All right. So that's your acutes. These can be caused by a ton of things. They can be caused by all these other conditions, converting. They can be related to Down syndrome, actually, is pretty closely related. For whatever reason. I'm not actually sure. I suppose that trisomy ruins or affects your cell division sometimes. maybe it makes it more likely to have a translocation. That could be what it is. Okay. All right, so now that we've covered that, we're going to talk about the rest of our lymphoid problems. So, unlike myeloid, right, your lymphoid cells can start at the marrow. They also could be in the lymph nodes, right? Lymphadenopathy. You won't really see lymphadenopathy as much with myeloid, right? But you will with lymphoid, because you'll have big growth in the lymph nodes. And I guess you could also have it at the thymus, but I don't really see a lot of thymus ones. It's either lymph nodes or bone marrow or blood, right? And that's why we have lymphomas, because it could be at the lymph node. Whereas this is either bone or blood. This could be bone, blood, or lymph node. So we have lymphomas. Cool, lymphomas. And lymphomas can be split between Hodgkin and non-Hodgkin. So what is a Hodgkin? Hodgkin is, it has a Reed-Sternberg cell. So a Reed-Sternberg cell looks like this. It has these big nucleoli. So those are the photos of it. So they have more than one nucleus. They're just really ugly in a very specific way. Some call them owl eye like that, but they don't actually always have two. They could have three. But the point is the nucleolus is very visible. See that? In these ones. So that's a nucleus, and then it's condensed even in there. So that's what that is. That's why we call it owl eye. And so I suppose Mr. Reed and Mr. or Mrs. Reed, Mrs. Sternberg, whatever, somebody found out that these cells are more common for certain types of lymphomas. They look at the lymph nodes probably, and they found this, and they're like, what's going on? And so they call that a class. And there's different kinds. We can see if we get pictures of all four kinds. Okay, perfect. That's really good. Oh, and they got published in Nature. They deserve to get published in Nature if they have a nice photo like this, right? Come on. That's just shows effort. Okay, wow, this is beautiful. Wow, look at that. So there's a few different kinds we can compare. Let's delete these. I love some of these graphics I found. They're kind of beautiful. Okay, so there's the rich kind, where there's plenty of other cells here. I'm pretty sure that's what that is. So this one's actually nodular sclerosis. Is here. I want to start with rich. So where's the rich? Rich, LRHL. Here. So there's Reed-Sternberg cells around here. Where's Reed-Sternberg's? HRS is Reed-Sternberg. Okay, so that's your yellow. Yellow here is your Reed-Sternberg's. That's your B cells, and this is your histiocytes. So these are just normal cells that you would actually expect to see in a normal lymph node, right? So normal lymph node cells, but you got a few of these guys, right? So that's like a small-ish issue if you have rich. So that's why you have a high cure rate. They're not as bad. You could have the next thing where you have mixed cellularity, where you have mixed cellularity is MH right here. What's LDHL? Depleted. Okay. Yeah, we're going to go next to the cell rich. So now you've attracted quite a lot of different kinds of cells. And you have more Reed-Sternberg cells. But the problem is you've attracted all these other guys. Right, so now you've all of a sudden made this tissue more, you have weird infiltration. You have plasma cells. You have weird neutrophils. Just don't belong there, right? And that's not very good for your prognosis. But the worst of all, I believe, is if you have the depleted, right, is LDHL here. That's when you're losing out on some lymphocytes. So not only do you have a mix in here, but you also don't really have as many B cells anymore. I guess this one you also don't have as many B cells, but you have some fibrosis going on. It's less dense, supposedly. It looks more dense in this photo. I don't know why. It's supposed to be depleted. It doesn't look depleted to me. The other one is if you have nodular sclerosis, you see collagen bundles around it. That's this one over here. So the fibroblasts are getting in there and changing it up. I don't know if I can see a YouTube video. Maybe will tell us a thing or two. Let's see. Wow, catchy, bro. Sheesh. Let's go. Skip a little.
Approximately 33% of patients.
Here we go. Subtypes.
Approximately 5% of patients. The class is on cellular of Hodgkin lymphocytes depleted.
So let's see if we can take a look.
Of the nodular sclerosis.
This picture is horrible. What is that?
Mixed cellularity Hodgkin lymphoma occurs in approximately frequently than females. Occurs stage 4 disease. Lymphocyte-rich Hodgkin lymphoma component the name would see. In contrast, is a B symptoms occur in around suggest.
You said mixed has poor survival? I don't know. Well, I guess it doesn't look so poor to me. I guess things changed in the past couple years.
Less than 1% of patients at stage with lots of bizarre Reed-Sternberg type cells and very few lymphocytes. With classical Hodgkin lymphocyte of patients with Hodgkin lymphoma, 80% are male. It is nodular. Are lots of lymphocytes in a nodular configuration, hence the term nodular lymphocyte predominant. It is staged using both sides of the diaphragm.
Okay, I'm not gonna. Oh yeah, there's a staging as well. We'll talk about that as well. So how do we put this? We have to remember 30 and 15 as well for Hodgkin. essentially the richer you are, the better. Really. More lymphocytes that are still there, the more quote unquote normal you are, the better. Nodular, these are actually not that bad either. But you just have to look for the collagen. I don't know if I can compare nodular predominant as well from the photo. Oh, that's that one, I think. That's this one. This is nodular predominant. I don't know why. What's LP cell? But it will be separated a little more, I guess. These are actually really hard for me to tell the difference in. If I can recognize Reed Sternberg, that's probably good enough. All right, after that, all I need to know is that. And there's staging as well for Hodgkin lymphomas. So you're a lower stage if it's a single lymph node. If it spreads to more lymph nodes, that's 2. If it passes the diaphragm, so it's on either side of the diaphragm, that's a 3. And that's describing how invasive it is. If it's able to pass that diaphragm, it means something. And 4 means it's literally everywhere. Okay, so that's that. So that's Hodgkin's. All right, now we're gonna jump into non-Hodgkin. Non-Hodgkin, you can be B or T. CD3 is like a young T cell marker, as we can see here. CD3, or not young, sorry. CD3 is pretty. It's in B cells. It's in more mature. It's in like pretty good T cells versus 19 and 20 in B cells. Most are B cells, Hodgkin's. And note here that whenever there's a precursor one, I automatically turn it into acute lymphoblastic. We're talking about more well-developed T and B cells. Okay. All right. So let's do T cells real quick. So they can be high or low grade. The lower grade ones are actually related to the skin. So they will have CD7. What do we know about CD7? Oh, this is that one we learned about earlier, CD7, and these T cells here. I don't know too much about CD7, honestly, other than it's in these malignancies. But they'll be peripheral and maybe even at the skin. Only CD4 ones are at the skin. And they can cause mycosis fungoides. Which is a skin condition. And it looks like this. And they can even bulge out like that. Not great. Or if it's even worse, it could cause Sézary syndrome. So this is actually, sorry, I said that the patient I met was probably Rubavera, but I don't think it's Rubavera. I think it's more likely a non-Hodgkin T-cell lymphoma that that causes this Sézary syndrome. So let's look up Sézary syndrome. And so you turn very, very red. And you also have this peeling as well. But how does that work, right? It's when you have CD4 cells, and let's see, how does this happen? I guess they're just very active and very inflammation heavy. Not just in the skin, but they're also doing a lot. So that's does erythroedema. Oh, I guess erythroderma. Sorry, that's probably what it is, not erythroedema. Erythroedema would probably just be called bleeding. Yeah, erythroderma, and you also have these sort of abscesses happen as well. I think I spelled it wrong. Micro abscesses happening in the skin. Just does not look good. Yeah. Wow, that's terrible. It's like tiny, tiny blisters. Anyway, that's CD4 cells going haywire. Right. Your high grade ones include adult T cell lymphoma and anaplastic. So, what does anaplastic mean, right? Anaplastic means, I guess they're low differentiation, relatively, and they're not very well formed, I suppose, which would cause the horseshoe nuclei to happen. Like that. That's horseshoe. Okay. So you could see bands, and that wouldn't be too weird if we were to see it in neutrophils, right? Or young granulocyte. But it's not granulocyte, remember. This is weird because we're talking about lymphocytes. And adult T-cell lymphoma is related to a viral infection, HTLV1, which causes skin lesions and a flower cell, which actually looks quite like how it's described, flower cell lymphocyte. It's crazy, huh? Yeah, so that's your T-cell lymphomas. Ooh, okay. We've covered a lot already. We're not done yet. We're going to quickly run into the B cells. So B cell, they're going to have surface immunoglobulins because, I mean, yeah, they're pretty much mature B cells. And these are kind of hard to separate out. But if you see it in the blood, it's either hairy cell or it's small or it's chronic lymphocytic leukemia. And if it's hairy cell, then you're going to see the trap, which is a type of phosphatase on the surface, and you also see the hairiness. But another way to ensure it's hairy cell is BRAF, is a cell marker. And you need to compare that and make sure it's different from small lymphocytic, which has a leukemic phase. And this one is actually the most common and the best treatable one. So it has CD5. CD5 is interestingly a T cell marker, if we remember, T cell CD5. So it has that, but also has CD23. interestingly. I guess that's like a basophil sort of a looking thing. Weird. I don't know why it has that. So you have to compare these and make sure you get the right one. And then the next one you have to compare is between small lymphocytic and mantle cell. Mantle cell does not have CD23. It only has CD5. Okay. So let's compare some of these guys over here. I guess we could also talk about the small cells. That could be important too. There are several stages. I guess 3 and 4 is when it's systemic. 1 and 2 is, or when we're talking about spleen and lymph nodes. So we have blood, lymph node, spleen, marrow, that must be, and then different kinds of marrow effect. So that's how we stage it. So let's talk about the ones that are, because B cells are in the follicles, right? So we have to talk about the follicle. On the very edge of the follicle, we have marginal zone, and they have a lot of nodal, which they can be outside of the lymph nodes. They could be in the malt, where they can be H. pylori associated. So I guess what we have to say from that is the edge of the lymph node, it can be some infection. Follicular is a little worse, and there's different sizes, interestingly. This one has CD10, also in Burkitt's, which means it grows a little bit faster, I suppose. Mantle cell is actually really bad. Mantle is on the edge of the follicle, and that's a lot worse. I don't know why the location matters. Maybe it's not location, and maybe it's the cell signal that matters, but I'm not really sure. But the diffuse large B is probably one of the worst, and so it's very large and very diffuse. It doesn't stay in defined lines. Burkitt's lymphoma is caused by EBV, which I've also detailed down here. Which starts with a B cell, then kills T, and then once your T cells have killed all of your B cells, then you're going to have issues with antibodies. And your antibodies are going to look weird. That's a big Epstein-Barr problem. So that's what's happening here. You're going to have these weird B cells. And they have a starry sky pattern. Let's see the Burkitt starry sky. So essentially you have these big histiocytes, is what I know about. And then they're inside of the lymph node for some reason. Yeah. Macrophages, right, exactly. It's caused by infection, and the macrophages are trying to fix the infection by killing your B cells. So that's all of these. That's quite a lot to remember. And then, once your B cells have fully matured into plasma cells expressing CD138, then you're going to have a lot of other issues. You can have myelomas. So why is it called a myeloma? Why mile? Right. Where did this word originate? So from marrow. Okay, so because a lot of your plasma cells are in the marrow, I guess, so it's called a myeloma. Sure, why not? As opposed to myeloid. I don't know why myeloma is. I guess it's in your marrow. Sure, why not? The biggest famous one is multiple myeloma, which causes a lot of proliferation of these cells in your marrow, and you also have a lot of these monoclonal antibodies being made. Plasmacytoma, so multiple myeloma, they'll actually leave the bone, some of them. Plasmacytoma is actually not in the marrow yet, it's next to the marrow. And then non-IgM gammopathy is a malignancy that's, I don't think, I don't even think it's related to the bone yet. Yeah, of undetermined significance. So there's a weird antibody sign, but you haven't found any lesion or anything bad yet. Not as bad yet. Right, so that'll become plasmacytoma, which can become multiple myeloma once it gets into the marrow. There's also lymphoplasmacytic lymphoma, which is not in the marrow, I guess. It's in the lymph, which can also cause your thick blood, Waldenstrom's hyperglobinuria. But this time you're filling it not with blood cells, but something else. It's a ton of white blood cells. So these guys are going to act, these B cells are not going to act their age, really, and they're going to explode out into the blood, where they cause a lot of other problems. And these are like kind of immature. So these would be like, they became plasma cells, or they essentially became plasma cells, very immature plasma cells, and they're doing wrecking havoc. That's what that is. There's a lot of things to remember. I don't think I'll remember most of it. But the main thing I think I should think about is Philadelphia being bad for acute. Okay. Neoplastic histiocytes. This is when you have a cancer of the monocytes and dendritic cells. I don't think we need to know too much about that. I guess there's a lot of signs for it. S100 antigen, Birbeck granules, they're the tennis rackets. But you have a ton of these weird cells going on. How do we differentiate that from myelogenous? They're not really granulocytes this time. And there's a few different kinds, unifocal, multifocal, and unisystem, multisystem. But they can just be all over and cause a lot of infiltration and problems. Whew, okay, so I think we did it. That's a lot to go through. But I think we got the basis down. Okay. We can go quickly into antineoplastic agents, and then we really need to pick up the pace because it's 11:16. So I put them all in one. So, okay. Similar to the other set of drugs that we were looking at, which was drugs affecting blood formation. I think I also had immunosuppressants. There's some similarity between immunosuppressant and anti-neoplastic, in the sense that we're trying to kill immune cells sometimes, right? Antimetabolites, we can affect DNA synthesis. Methotrexate, we've talked about a ton for folic acid. And we're lowering the activated tetrahydrofolate form so that we can lower the synthesis of nucleotides. I don't know all the details about 6-mercaptopurine and fluorouracil. Other than that, it just it just messes up the DNA that's formed. Either lowering, so most of these just mess with the enzyme, but this one can actually also be incorporated, which is interesting. I think hydroxyurea we should keep in mind because hydroxyurea affects both. Whew, that's a lot. Okay. Microtubule inhibitors. What we need to know is between which one increases tubulin and which one lowers tubulin. So paclitaxel increases it, and vincristine lowers it. So we should think about that. Okay. Out of DNA alkylating agents, you're going to be messing with the DNA somehow, right? Either you are cross-linking it. It depends on different sites, but guanine is your most common site. All four of these are guanine cross-linking to different regards, but we should think about guanine. Except for one of them, which does methylation. And this one, carbamoyl group. Oh, but there's a lot. I'm probably not going to remember a lot of that. There's topoisomerase inhibitors, which can have a lot of toxicity because it's really messing with your cell division as well. Steroid hormones. You're trying to lower the effect of certain factors in growing, and a lot of steroids are helpful for growing some of your your tumor cells. So aromatase, GnRH analog, and selective estrogen. So there's modulators and downregulators. There's fully antagonists and there's the competitive ones. Which will increase the function for a little bit and then decrease it. So I guess they're not as terrible, not as strong as the other ones. One of these for HER2. Which one for HER2? In any case, targeted, there's a ton. Where was we learned about one that we should think about? Gleevec. Here, this one. Gleevec is for a very specific one. All right, that's terrible. There's a lot going on here, and I will not be able to get it all. But we can think about these main effects. Okay, that's that. I did my best. So we're done with cancer. I will be back quickly and we can talk about infection. All right. Okay, we're in the final stretch. Let's start with hematologic infections. Let me glance at immune infections. Wow. Okay, we're going to compare these. That is a lot going on here. Okay. Here's the two side by side. And I'm also going to get out... I don't need to do any of the other ones. Okay, let's compare these. Wow. Okay. Start with hematologic. Let's talk about ones that just live in the blood. They don't do anything, just your classic, they just sit there. So, of course, there's protozoans. Of course, there's trematodes. Because these are a little bit bigger, and we can't really have bacteria and viruses that are just growing in the blood without causing damage. Unlikely. You got to be bigger. Okay? So, protozoans, you got apicomplexans and flagellates. These guys got the weird muscle. They look like little slugs, honestly, right? How they move versus they swimming. And it seems like all of these are transmitted by different things. Babesia by the tick, Plasmodium by malaria. So Plasmodium we can think about pretty easily by the mosquito is malaria. We just think about malaria. Anything Plasmodium, malaria. 5 axes in America. Okay, that's a cool fact. I don't know if I'll remember that. So if you're thinking about apicomplexans, think Babesia, Plasmodium in the blood. Okay. Cool. Flagellates, think Trypanosoma. Let's get a photo of Trypanosoma. These are little nasty little worm things. Okay. Either by the fly or the Chagas disease, but they can cause sleeping sickness. Why? Because they invade the central nervous system. Apparently, these nasty little worms can get past the blood-brain barrier and get to the brain, so that's pretty bad. Okay. So when think trematodes, think Trypanosoma, think Plasmodium, think Babesia. Okay. Trematodes. Trematodes are flukes. So we think about schistosoma. The flukes being laying eggs, and the eggs are going to get stuck in places. The one that causes big liver damage, which one was that? I think that was Manzoni. Yes, that's right. So Mansoni, you got the lateral spine, big lateral spine, which is going to cause a lot of issues. These ones have lateral spines, but they're going to be in the blood. So all these are blood ones. Cool. Somehow we need to know sporozoite, trimastigote, cercaria. Are there forms of infection? That's going to be hard as well. If I can remember the name, that's good enough, I think. Cool. So these guys are able to live in the blood without causing, any of these other signs, right? I mean, you could cause sleeping sickness, which is horrible, but other than that, these guys can sort of live without destroying other cells directly. Great. Parvovirus is very well known for just wrecking your red blood cells. So this is actually one of the ways you can get anemia, because it'll just kill all of the erythroblasts. So, actually, a sign for parvovirus is if you have anemia, and then you have low reticulocytes, right? That would be a sign of parvovirus, because that means your blasts are all effed up and nothing's being made. Cool. Parvovirus. Of course, when we talk about hemorrhagic fever, we talk about severe ones, we're talking about bacteria and virus. Because these guys can't seem to live in our blood well. Makes sense, right? I think part of that is because our body is just so used to searching for bacteria and viruses that it just overreact and would just go crazy on these suckers, right? So that's probably why you'll have rashes, red blood cell leakage from rickettsia. So with rickettsia, think hemorrhagic fever. And there's a lot of viruses here. Dengue being one of them, called breakbone fever, flaviviridae, yellow fever, hantavirus, these like rodents apparently, arenoviridae, which have sandy ribosomes, and then Ebola is a filoviridae. So these all are going to cause crazy. So this one's really crazy because it's gonna screw up all your blood cells, but then not only is it going to kill them, it's also going to cause clotting. So these are going to be killing your blood cells. It's pretty bad, all of these guys. I think out of all of these, these might be some of the worst. Right here, hemorrhagic fever. So relapsing fever is when you have, I think it's a bacteria that reproduces in waves. Oh, that is disgusting, man. Ooh, Lyme disease. Oh, Lyme disease bacteria. But they reproduce all together in waves, and then that's going to cause crazy fever, and then it'll be okay, and then it'll crazy fever again. So angiomatosis is kind of a very special case, I suppose, that causes skin nodules. So why does Bartonella cause skin nodules? If I remember correctly, is Bartonella dog related? It's louse and cat related. Okay. Wow. I don't really know how. I'm going to move on. Wow. Okay, so that's a lot, right? Babesia and Plasmodium, Trypanosoma. Trypanosoma is protozoan. Okay. Schistosoma. Okay, we know schistosoma. That's an old one. If it's a virus, probably going to be either parvo or it's going to be hemorrhagic fever. Borrelia versus Bartonella is going to be a little rough. Um, Rickettsia, you can think about as well. Okay, so pretty rough. Now let's compare over to immune system infection. Lymph node infection appears to be caused by a variety of cells, but what's the best way to approach this? Let's talk about the ones that do myelocytes first. These tend to be obligate intracellular guys, all of these I think can live inside of a cell for some time. Only a few of these have to be inside of a cell. Ehrlichia and Anaplasma are your classic tick ones that have to be inside. Coxia and Brucella, not so. Francisella, we have to remember, is the big rabbit blood one that causes lymphadenopathy. Bartonella cat scratch, which we already learned over here actually, is also involved in the lymph nodes. It's not just the skin. And Yersinia, we obviously already know, but it's going to kill phagocytes. It's going to hitch a ride and cause all of your lymph nodes to burst, which is horrible. Hemophilus is going to be sort of just living there and not doing as much. This is that painful ulcer. I think Hemophilus. The other genital ulcer is chlamydia. Which is obligate intracellular. When we think fungi in lymphadenopathy, we think sporothrix, which is in roses. That's a lot to remember. God. But the dimorphic part is actually very important because it's going to change temperature, and that's going to be the way that you catch it. Faleriform, nematodes the worms can also live in your lymph nodes, which is crazy. Either Brugia or Wucheria. That's crazy as well. It's going to live in there. It could cause elephantiasis, right? That's what happens when a worm stuffs up your lymph vessel. Okay, lymphocytes. So now we get into T and B cells. Obviously, HIV and HTLV are big. The retrovirus ones can hitch a ride into the follicles and kill your T cells. Whereas the B cells, you have EBV, which is classic. We already know about, which increases memory B cells. It's going to cause your dang it. It's going to cause your Burkitt's lymphoma. Sorry, I forgot about that. Burkitt's lymphoma. There's a lot to worry about for EBV. And cytomegalovirus is not very cancer-causing, but it will cause inclusions, which I guess you could confuse for Reed-Sternberg. So, because those will look kind of similar. But I guess CMVs are usually bigger. And I guess they look more like that. The nucleolus is even bigger than Reed-Sternberg. But they both have that sort of thing going on. That's a lot. Okay. Whew, baby, that's a lot. With the remaining couple minutes, we're going to do HIV. We just don't have any more time to worry about a lot of this stuff. And I think it's okay too, because this is not core. This is all sort of icing on the cake, right? So let's talk about HIV first. HIV. Transmissions, body fluids, we know that. Not too confusing. Structure, it has an envelope. And it has a protein, several genes, right? GAG is your outside. I don't know why it's called GAG. It just doesn't really make sense to me. Pol makes sense because it's your polymerase and your important machinery. And then EMV is envelope, going to help you gain entry. Okay. It has some other regulatory and accessory to help you help these machineries, the Pol, work. So these are going to team up with that. It has diploid mRNA. The mRNA itself is not infectious, but once it gets turned into the DNA, gets integrated, that's bad news. So HIV actually hitches a ride on the dendritic cell, and it gets taken to meet the T cells, where it then kills them. And CD8 cells actually are the ones that kill the infected helper T cells. So that's why you have first an acute your HIV expands inside of the CD4 cells, and then your T cells start killing them, right? And then you eventually lose them all, and you have AIDS. There's a lot of ways of preventing it as well. So that's pretty simple, I think, when we talk about HIV. I think one of the things that we have to think about is the importance of some of these over here. The GP41 is fusion versus 120, which is initial binding. So we have to think about that in a minute when we go over to drugs. Moreover, protease is important in activating it after budding, whereas these two are important in initial infection. So we're going to talk about that now. Okay. So there are several different kinds of inhibitors. First of all, we don't want the virus. I think one of the easiest ways first is to make sure that we try and kill the virus or make it break the virus while it's in the blood. That's our protease inhibitor. What's the best way to do this, actually? Let's start here with entry, right? First of all, we don't want it to enter, so we can... so these are actually going to tell you a lot about it. So all of these attachment ones are for GP120, which is going to bind to CD4. So that's how the cell initially gets in. And the GP41 is the part that allows the virus to enter. So binding versus entering is sort of different. So you can either prevent it from happening, or you can mess it up while they're attached. And you can either bind it on the virus, or you can actually bind the CCR5 on the cell. So CCR5 is on, I believe CCR5 is on the dendritic cells. Sorry. CCR5 over here you can see is on the macrophage. Oh, and dendritic cell. But CXCR4 is macrophage only. But anyway, this is to prevent it from getting in there. Notice if you have CXCR4, then it can enter a macrophage. You'll have the problem will still happen. right? So that's why it can be better to just bind the virus instead of binding the body cell, right? And then the gold standard really is the reverse transcriptase inhibitor, which is less side effects. That's why this nucleotide one is used most often for prophylaxis and for post exposure, for either pre or post exposure. And it can also be used for HBV, so you gotta think about that as well. Somehow, I don't know why this is involved in HBV, but so these are gonna get incorporated pretty much. Actually, yeah, these are gonna get incorporated and terminate the growth, sort of like how we do in sequencing, really, the DDNTPs, the dideoxynucleotide, right, instead of normal deoxy. We have non-nucleotide ones that are inhibitors of our reverse transcriptase. And there's a ton here. God, I don't think I'll remember these. Wow. There's integrase inhibitors, which are going to prevent the virus from entering from incorporating into the cell. A lot of side effects from that. Even teratogen. So this is I mean, this makes sense, right? Because how it does that is very, it can affect other cells perhaps as well, you know. I don't know too much about the mechanism, so I can't specifically talk about why, but and then once it's fully in the cell, so the cells are, it's entered already, it's already done the RT, it's already done the integration. Now it's budding out of the cell, and you don't want it to infect other cells as easily. That's what a protease inhibitor is. It's kind of like the cell saying, okay, you got me, right? But I'm going to make sure we both die, right? I'm going to make sure that whatever you win from killing me, you know, I also destroy that so you don't gain anything. So that's going to keep it from arming the reverse transcriptase. Whew. How am I going to remember these? Honestly, it's 11:44. I'm pretty confident I can say I just won't remember these and hope everything works out. Great. Let's take a look back here. Did we cover everything? That's everything. Wow. Okay. So my voice is starting to die, and I have been on here for so many hours. I can't guarantee that I know most of the material, but what I can say is that I have at least a very solid foundation. So whatever happens from here on out, we'll see, right? We can at least reason some of it. I'm going to go get more Peepuckle and get ready to go to bed, but that's it. Hopefully this coverage is helpful in some way. Okay. Over and out. Yeah. I'm so surprised I finished, actually, even after playing and winning that I Am Volleyball game. That's crazy.